If your parent or spouse is admitted to a hospital and someone hands them a form to sign, stop. Read every word of that form. Because one specific document, signed in a hospital bed while in pain and medicated, can eliminate tens of thousands of dollars of Medicare coverage that you believed was activated the moment they walked through the emergency room door. The form is called the Medicare Outpatient Observation Notice. The Moon. The hospital is legally required to give it to you. They are not legally required to explain what it means in plain English. They are not legally required to recommend that you seek clarification before signing. They hand it to you, often at 11 p.m., often when you are managing a frightened spouse or a disoriented parent, often when the nurse is waiting and the room needs to be set up, and they wait for a signature that eliminates your right to challenge the classification that determines whether Medicare pays for the next 3 weeks of your care. And that classification, observation status versus inpatient status, is a billing decision made not by your doctor but by the hospital's utilization review department. Your doctor may want you admitted. Your doctor may believe you are inpatient. The utilization review team, operating under financial guidelines designed to protect the hospital from Medicare audit penalties, may classify you as observation. And unless you know what the moon says and why it matters, you will sign it, go to sleep, and wake up to a bill that Medicare's Part A coverage does not apply to. Roger and Nancy Ashworth are 78 and 75 years old. They live in a craftsman home in the Selwood Moreland neighborhood of Portland, Oregon. Roger is a retired high school history teacher, 33 years, AP United States History, coached the debate team until 2014. Nancy ran a small bookkeeping practice from their home office for 26 years. They have a golden retriever named Ellsworth. Roger makes sourdough every Friday. Their daughter Claire lives in Seattle, 45 minutes by air, 4 hours by car. In September 2025, Roger wakes at 3 a.m. with chest pain, shortness of breath, and disorientation. Nancy calls 911. Paramedics arrive in 7 minutes. Roger is transported to a Portland area hospital. He is brought through the emergency department, evaluated, stabilized, and moved to a room. He is in a hospital bed. He is wearing a hospital gown. He is receiving IV fluids, cardiac monitoring, and medication management. To Roger and Nancy, who arrive 45 minutes after Roger does, he appears to be admitted. He is in a room. He has a bracelet. He has a nurse. He is in the hospital. He is not admitted. He is under observation. The hospital's utilization review team, reviewing Roger's case the morning after arrival, determines that his presentation does not meet the criteria for inpatient admission under Medicare's 2-midnight rule, which requires that the physician expect the patient to require hospital care spanning at least 2 midnights. Roger's cardiac episode resolves within 36 hours. The utilization review team classifies him as observation status. On day 2 of Roger's hospital stay, a patient care technician brings a clipboard to his room. It contains the Medicare Outpatient Observation Notice. The Moon. Roger is tired. Roger's heart rate is still slightly elevated. Roger has been taking a mild sedative for sleep. The technician says, "This is just some paperwork about your stay. We need your signature." Roger signs. Nancy is in the cafeteria getting coffee. Nobody explains what observation status means. Nobody explains that the signature will affect coverage for a skilled nursing facility if Roger needs one. Nobody explains that Roger's hospital stay, which Medicare Part A would have covered with a $1,632 deductible for inpatient time, will now be billed under Medicare Part B outpatient rules, with a 20% coinsurance on each covered service, no cap, no Part A deductible applied. Roger is discharged on day 3. His disorientation, which cleared in the hospital, has returned in a mild form. His cardiologist recommends 30 days of skilled nursing facility rehabilitation to monitor his cardiac stability, adjust his medication, and ensure he can safely return home. Nancy contacts a Portland area skilled nursing facility. The facility requests Roger's Medicare coverage information. The facility's billing coordinator calls Nancy 2 days later. Roger's 3-day hospital stay was observation status. Under Medicare's 3-day inpatient stay requirement, codified in the Medicare Benefit Policy Manual, Chapter 1, Section 10, Medicare Part A will not cover skilled nursing facility care unless the patient has had a qualifying inpatient hospital stay of at least 3 consecutive days, not counting the day of discharge. Roger spent 3 days in the hospital, but he was not an inpatient for any of those days. He was observation. Observation days do not count toward the 3-day qualifying stay. Roger has 0 qualifying inpatient days. Medicare Part A will not pay $1 for his skilled nursing facility stay. The daily cost of the Portland area skilled nursing facility, $395 per day, 30 days, $11,850. Medicare Part A would have covered all of it after the deductible for days 1 through 20. Roger and Nancy will pay every dollar of it because Roger signed the moon without understanding what it meant. That is the crime scene. A signature on a form taken at 11 p.m. on day 2 of a hospital stay from a man who was tired, medicated, and did not know what observation status meant because the hospital did not explain it, and the form's 800 words were not designed to be understood by someone in that condition. If that sequence, the bed, the bracelet, the nurse, the coverage that does not exist, lands the way it should, smash that like button right now, because the appeal rights, the reclassification mechanisms, and the BIPA protections I am about to show you are the difference between Roger paying $11,850 out of pocket and Roger receiving the skilled nursing facility coverage he should have had from the moment the ambulance arrived. Let's build the complete observation status damage map, because the $11,850 skilled nursing facility bill is the immediate cost. The cascade of financial consequences that flows from the observation classification produces a damage total that most families do not understand until months after discharge. The suits at the agency want me to remind you this is not financial advice. It is a survival guide for an unguarded vault. Talk to a Medicare counselor or elder law attorney before signing any hospital form or initiating any appeal. Your state's SHIP program provides free guidance. Cost Layer 1. The Part B coinsurance on the observation stay. Under inpatient status, Roger's 3-day hospital stay would have been covered by Medicare Part A, $1,632 deductible in 2026 for the first 60 days, 0 coinsurance. He would pay $1,632. Under observation status, each service during the 3-day stay is billed under Medicare Part B, outpatient rules. Part B covers 80% of approved charges after the $240 annual deductible. The patient pays 20% coinsurance on every line item, with no cap on out-of-pocket exposure under Part B alone. Roger's 3-day observation stay, cardiac monitoring, $3,400. IV medications, $1,200. Laboratory, $890. Physician visits, $620. Imaging, $780. Total Medicare-approved charges, $6,890. Medicare Part B pays 80%, $5,512. Roger's 20% coinsurance, $1,378. Plus prescription drugs given during the observation stay. Observation status medications are not covered by Medicare Part A hospital coverage. They may or may not be covered by Roger's Part D plan, depending on formulary. Out-of-pocket drug cost during the stay, $340. Total observation stay out-of-pocket, $1,718. Compared to inpatient, $1,632 deductible, 0 coinsurance on days 1 through 60. The observation stay actually costs Roger slightly more for the hospital stay itself, $1,718 versus $1,632 DIAS, but the difference is modest. The catastrophic difference is what comes next. Cost Layer 2. The skilled nursing facility coverage loss. This is the catastrophic layer. Roger's 30-day skilled nursing facility stay at $395 per day, $11,850. Under Medicare Part A, following a qualifying 3-day inpatient stay, $0 for days 1 through 20, $200 per day coinsurance for days 21 through 100. Roger needs 30 days. He would have paid $2,000 in coinsurance, 10 days at $200, with Medicare covering the remaining $9,850. Under observation status with no qualifying inpatient stay, $11,850 entirely private pay. Medicare pays 0. The coverage gap, $9,850. The cost Roger bears because of the classification decision made by the utilization review team on the morning of day 2. Cost Layer 3. The Oregon Medicaid spend-down interaction. Roger and Nancy have combined assets of approximately $380,000. The $11,850 SNF bill and the $1,718 observation stay coinsurance consume $13,568 of those assets, reducing the estate by 3.6% in 30 days from a medical event that Medicare should have covered. If Roger needs a longer-term skilled nursing facility stay in the future, which at 78 with a cardiac history is a statistical probability, the observation status classification this September will not reduce his future Medicaid spend-down calculation, but it establishes a precedent. The hospital's classification in September 2025 creates documentation that Roger's care does not require inpatient hospitalization, which Medicaid planners and hospital utilization review teams may reference in future admission decisions. Cost Layer 4. The Medicare Supplement, Medigap Gap. Roger and Nancy have a Medicare Supplement Plan G. Plan G covers the Part A deductible, the Part A coinsurance for days 1 through 60, and the Part B coinsurance, but only to the extent that Medicare Part B covers the underlying service. The 20% Part B coinsurance on Roger's observation stay covered by Plan G, but the skilled nursing facility costs under zero Part A coverage, not covered by Plan G, because Plan G covers Part A SNF coinsurance for days 21 through 100 only when Part A is paying for days 1 through 20. With zero Part A coverage, the Plan G SNF benefit is irrelevant. Roger has a Plan G, and it does not help him with the most expensive consequence of his observation status classification. Total observation status financial damage: $1,718 observation coinsurance, largely covered by Plan G, $11,850 in uncovered SNF costs, not covered by Plan G, $340 in uncovered observation medications. Net out-of-pocket after Plan G, approximately $12,190, against the $1,632 in patient deductible that Plan G would have covered entirely. Tell me in the comments right now, how old are you this June 2026, and has anyone in your household been hospitalized in the last 3 years with an observation status classification? Tell me what state. Tell me whether you were given the moon notice and whether anyone explained what it meant. This thread needs to document how many families have walked into this trap. Here is the open loop I need you to hold. There is a federal appeals process, established by a class action lawsuit settled in 2024, known as the Bagnall settlement, that allows Medicare patients classified as observation status to request a formal review of their inpatient classification. This review was not available prior to 2024. It gives Roger and Nancy a pathway to challenge the September 2025 classification and recover the SNF coverage retroactively. It requires a specific form, a specific filing timeline, and a specific set of supporting documentation. Most families have never heard of the Bagnall settlement. Hold that. We're almost to the strategy. Let's name who designed the observation status trap and who profits from its existence. The two-midnight rule, Jiuang, the standard under which a Medicare patient is classified as inpatient if the treating physician expects their care to require hospital services spanning at least 2 consecutive midnights, was introduced by the Centers for Medicare and Medicaid Services in 2013. Prior to 2013, the inpatient classification criteria were less precise, and hospitals were subject to recovery audit contractor audits that clawed back Medicare Part A payments for hospitalizations CMS deemed unnecessary. Hospitals were penalized financially for classifying patients as inpatient when CMS auditors determined the care did not meet inpatient criteria. The result: hospitals began classifying borderline patients as observation rather than inpatient to protect themselves from audit penalties. Observation status allows the hospital to bill under Part B, which typically pays less per episode than Part A for uncomplicated cases but eliminates the audit penalty risk. The financial calculus favors observation for the hospital on any admission where the 2-midnight threshold is uncertain. The patient's financial calculus is exactly opposite. Observation status eliminates Part A coverage of the hospital stay, eliminates the 3-day qualifying period for SNF coverage, and potentially exposes the patient to uncapped Part B coinsurance on inpatient equivalent care, the same IV drip, the same monitor, the same nursing assessment, delivered in the same room, costs the hospital-classified inpatient patient $1,632. It costs the observation-classified patient $12,190 after Medigap. The hospital system, a $1.3 trillion annual industry, profits from the observation classification in two ways. It avoids audit penalties on borderline cases, and it collects Part B coinsurance from patients and their Medigap plans on services that, under inpatient status, would have been covered under a flat deductible. The incentive to classify borderline patients as observation is structural and financial. The Moon Notice, the Medicare Outpatient Observation Notice mandated by 42 CFR Section 489.20Y since 2017, was designed to address this information asymmetry. Congress required hospitals to notify patients in writing when they were classified as observation status and to explain the financial implications. The law was passed. The regulation was issued. The Moon Form was created. What the regulation did not require, that the notice be delivered at a time when the patient has capacity to understand it, that the patient be given a waiting period before signing, that the hospital provide a verbal explanation in addition to the written form, that the notice include the dollar amount of coverage the patient is losing by the classification, that the hospital explain that the patient has the right to request inpatient reclassification before discharge. The form was required. The comprehension was not. And for a 78-year-old man who has been in the hospital for 36 hours with a cardiac event, has taken a sedative, and is handed an 800-word form on a clipboard at 11 p.m. by a staff member who says, "It's just some paperwork." Comprehension is not what happens. Send this bulletin right now, before it ends, to one person whose parent or spouse has a hospitalization in their future. The observation status trap activates on the day of admission, not the day of discharge, not the day the SNF bill arrives, the day the utilization review team makes the classification decision. The only moment when the trap can be prevented is the moment of admission, and the only way to prevent it is to know, before anyone in your family is in that hospital bed, that the classification exists and that you have the right to ask about it and challenge it. Send it. Today. Not after someone in your family is already in a hospital room. 5 strategies. Spanning the prevention window before admission, the active management window during the hospital stay, the appeal window after discharge, and the long-term planning instruments that reduce financial exposure regardless of classification status. Save this video to a playlist titled Retirement Survival Manual right now. What follows is the hospital navigation framework that a Medicare patient advocate or elder law attorney experienced in observation status cases would charge $2,000 to $5,000 to provide during an active hospitalization. The architecture is here. The advocate executes it in real time. Strategy number 1. Ask the admission question before signing anything. The single most powerful intervention in the observation status trap costs nothing and takes 30 seconds. When any family member is admitted to a hospital, whether through the emergency department, a scheduled surgical admission, or a transfer from another facility, the responsible family member or patient advocate asks one question. Is this patient being admitted as an inpatient or as outpatient under observation status? That question, asked directly to the admitting nurse, the attending physician, or the hospital's patient services representative, initiates a disclosure that may not otherwise occur for 36 hours. Under federal law, 42 CFR Section 489.20Y, the hospital has 36 hours from the start of observation status to deliver the Moon Notice. 36 hours in which the patient may receive inpatient equivalent care while being billed as outpatient without knowing the difference, asking the question on admission before the 36-hour clock even starts, gives the family information while the patient still has maximum capacity, maximum time, and maximum ability to request reclassification. If the answer is observation status, the family has 3 immediate actions. 1. Request a case manager meeting. Every hospital has a case manager or utilization review coordinator. Request a face-to-face meeting within 2 hours. Ask the case manager to explain the 2 midnight rule, why the patient has been classified as observation, and what the attending physician's expectation is for the patient's length of stay. If the physician expects care spanning 2 or more midnights, the physician can document that expectation and support an inpatient reclassification request. 2. Request the attending physician place an inpatient admission order immediately if clinically appropriate. The 2 midnight rule gives the attending physician authority to admit as inpatient when their clinical judgment is that the patient will require 2 or more midnights of hospital care. The physician's order, made at admission, documented in the medical record, is the strongest single tool for preventing observation status. 3. Do not sign the Moon Notice immediately. Read it in full. If you cannot understand it, request a verbal explanation from the case manager before signing. The notice itself triggers an appeal window, but signing it without understanding it does not waive your appeal rights. Your signature on the Moon acknowledges receipt, not agreement with the classification. State nuance. Oregon does not have a state-level observation status protection law beyond the federal Moon requirement. California enacted AB 1824 in 2022, which requires hospitals to provide a more detailed notice of observation status financial consequences and to include an estimate of out-of-pocket costs under both observation and inpatient scenarios. California patients have stronger state-level disclosure rights than patients in most other states. New York has enacted similar enhanced disclosure requirements. Federal protections apply in all states. Strategy number 2, file the inpatient reclassification request during the stay. If observation status is confirmed after the attending physician has been consulted and the utilization review team maintains the classification, the patient has the right, each under the CMS Beneficiary and Family-Centered Care Quality Improvement Organization process, to request expedited review of the observation classification before discharge. This request must be filed with the Beneficiary and Family-Centered Care Quality Improvement Organization, known as the BFCC-QIO for the patient's state. In Oregon, the BFCC-QIO is Levanta LLC, reachable at 1-888-852-4999-00. The request triggers a review process that can result in the hospital being required to change the classification from observation to inpatient E, but the review must be initiated before the patient is discharged. Once discharged, the expedited review process under the BFCC-QIO is no longer available. The request process, call the BFCC-QIO number, provide the patient's name, Medicare number, hospital name, and a statement that you are requesting expedited review of the inpatient classification. The QIO has 72 hours to issue a determination. During that 72 hours, the hospital may not discharge the patient without consequence. The patient is protected from premature discharge during the review process. If the QIO determines the patient should have been admitted as inpatient, the classification is changed retroactively, and Part A coverage applies. This expedited review, the most powerful real-time intervention available, is used by a tiny fraction of the families who need it because most families do not know it exists. The hospital does not volunteer this information in the Moon Notice. The attending physician does not mention it. The case manager does not raise it unless directly asked. State nuance. The BFCC-QIO for each state is listed at cms.gov/medicare/quality-patient-assessment-instrument/quality improvement orgs. Oregon's BFCC-QIO is Levanta. California's is Levanta. Florida's is KEPRO. Texas's is KEPRO. The process is identical across states. The QIO name differs. Strategy number 3, the Bagnall settlement appeals process after discharge. Here is the mechanism I told you to hold, the Bagnall versus Becerra class action, settled in 2024. Established for the first time in Medicare history, the right of Medicare beneficiaries classified as observation status to appeal that classification after discharge through the standard Medicare appeals process. Prior to the Bagnall settlement, patients who were discharged under observation status had no meaningful post-discharge appeal rights for the inpatient classification itself. They could appeal billing amounts, but not the classification decision. Under the Bagnall settlement, any Medicare patient who was placed under observation status on or after January 1, 2009 may file a Medicare appeal challenging the observation classification and requesting reclassification to inpatient, with retroactive coverage implications. The appeal is filed by completing a redetermination request form. CMS-20027 and submitting it to the Medicare administrative contractor that processed the claim. For Roger and Nancy, the September 2025 observation stay is within the Bagnall appeal window. Roger's attorney, contacted through the Oregon SHIP program, which identified the Bagnall settlement pathway during a December 2025 counseling appointment, filed a redetermination request challenging the observation classification based on the attending cardiologist's documented clinical expectation that Roger would require 2 or more midnights of cardiac monitoring. The cardiologist's documentation, combined with the 3-day hospital stay and the cardiac instability noted in the discharge summary, provides a strong record for the reclassification request. The timeline for Bagnall appeals. The Medicare administrative contractor must issue a redetermination within 60 days of receiving the complete request. If the redetermination denies the claim, the beneficiary may escalate to a qualified independent contractor (QIC) review, then to an administrative law judge, then to the Medicare Appeals Council, and ultimately to federal district court. The full appeals process can take 6 months to 2 years, but at each level, a successful appeal produces retroactive coverage for the observation stay and the SNF stay, potentially recovering the full $12,190 Roger paid out of pocket. State nuance. The Bagnall appeals process is federal and uniform across all states. However, the success rate of appeals varies significantly based on the clinical documentation in the hospital record and the quality of the supporting medical opinion. States with active Medicare patient advocacy organizations, California, New York, Massachusetts, have better developed support structures for preparing Bagnall appeals. Oregon has a robust SHIP program that can identify attorney referrals for complex observation status appeals. Strategy number 4. The Medicare Savings Program and QMB protection for Medicare beneficiaries with lower income below approximately 100% to 135% of the federal poverty level. The Qualified Medicare Beneficiary Program provides a specific protection against observation status financial harm. QMB beneficiaries cannot be billed for Medicare cost sharing, including Part B coinsurance, regardless of observation status classification. If Roger and Nancy's income were at or below the QMB threshold, individual income under approximately $22,000, couple income under $29,000 in 2026, the 20% Part B coinsurance on the observation stay would be prohibited. Providers who bill QMB beneficiaries for Medicare cost sharing violate federal law and can be reported to the state Medicaid agency. Roger and Nancy's income of approximately $58,000 in combined Social Security and investment income places them well above the QMB threshold. But for the significant portion of the 65-plus population watching this bulletin with more modest retirement income, the QMB protection is directly relevant to the observation status financial harm. A QMB beneficiary who receives an observation status bill can contact their state Medicaid agency and report the billing violation, which can result in the charge being eliminated entirely. More broadly, Oregon's Medicare Savings Program income thresholds, available through OHA, the Oregon Health Authority, should be reviewed annually by any Medicare beneficiary whose income is below $35,000 as a single filer or $47,000 as a couple. The MSP protections, including QMB, SLMB, and QI, eliminate or reduce Medicare premiums, deductibles, and coinsurance for qualifying beneficiaries, providing a structural financial buffer against exactly the kind of unexpected cost the observation status trap produces. State nuance. Oregon's QMB income thresholds follow the federal minimum with a modest state expansion. California has higher QMB thresholds. California's Medi-Cal program provides broader MSP protection, extending QMB eligibility to higher income levels than the federal minimum. In Texas and Florida, MSP thresholds are at the federal minimum. The Oregon SHIP program, accessible at 8007-224134 or oregonshines.org, screens for MSP eligibility in the same counseling appointment that addresses observation status appeals. Strategy number 5. Secure the 3-day inpatient stay before any planned hospitalization for any hospitalization that is planned, elective surgery, scheduled procedures, deliberate medical interventions. Families have advance opportunity to confirm inpatient status before the admission date, while the patient is healthy, unmedicated, and fully capable of advocating for themselves. Pre-admission protocol. Before any planned hospitalization, the patient or family advocate contacts the hospital's patient services or case management department and asks specifically, "Will this patient be admitted as Medicare inpatient for this procedure?" If the answer is observation or uncertain, escalate to the attending physician and request a specific inpatient admission order prior to the hospital date. For procedures where the treating physician expects recovery to span at least 2 midnights, which includes most orthopedic surgeries, cardiac procedures, and neurological interventions, an inpatient admission order placed in advance, documented in the pre-admission record, and confirmed in writing by the treating physician is the strongest protection against observation classification upon arrival. Pre-admission documentation: request a letter from the treating physician confirming inpatient admission and stating the clinical basis, the expected length of stay, the medical complexity justifying the classification, and the physician's expectation that the care will span at least 2 midnights. Bring this letter to the admission. Provide it to the admitting nurse and the case management team. The letter creates a documentation record that the utilization review team must address if they consider reclassifying the patient to observation. State nuance. Oregon does not have a state-level pre-admission inpatient confirmation requirement. New York, which has enacted some of the strongest state-level patient protections around hospital observation status, requires hospitals to notify patients of their admission status within 12 hours of placement in a hospital bed, earlier than the federal 36-hour moon requirement. Patients in New York should request the 12-hour notification explicitly, if not volunteered. In California, AB 1824 requires the hospital to provide a cost estimate alongside the observation notice. California patients should receive this estimate and use it to inform the appeal decision. Let me bring Roger and Nancy back one final time. Roger Ashworth is home. He is recovering. The cardiologist has adjusted his medication. The 30-day skilled nursing facility stay was completed in October 2025. The bill for $11,850 arrived in November. It was not what Roger and Nancy expected. It was not what Plan G was supposed to allow. Their Bagnall appeal was filed in December 2025 with the assistance of an elder law attorney identified through Oregon SHIP. The appeal includes the attending cardiologist's letter documenting his clinical expectation of 2 or more midnights of cardiac monitoring at the time of admission, the 3-day hospital discharge summary showing cardiac instability through day 2, and a formal challenge to the utilization review team's classification on the grounds that it did not reflect the attending physician's documented clinical judgment. The appeal is pending. It is June 2026. The appeal determination has not yet been issued. The Medicare administrative contractor has 60 days from the filing date to issue a redetermination. Roger and Nancy are waiting. The $11,850 has been paid. They did not want it to go to collections while the appeal is pending. If the redetermination succeeds, they receive a credit or refund. If it is denied, their elder law attorney has advised escalating to the QIC review level, where the clinical documentation in Roger's case is strong. What Roger and Nancy know now that they did not know on the morning of September 15, 2025, when the patient care technician brought the clipboard to Roger's room: observation status exists. The moon is the form that discloses it. The BFCC-QIO can review it before discharge. The Bagnall settlement can challenge it after discharge. The attending physician's order is the most powerful weapon against it. And the question asked at the moment of admission before any form is signed is the cheapest and most effective intervention of all. This channel publishes early warning bulletins within 48 hours of a CMS update to the 2 midnight rule, a federal court decision in observation status litigation, a congressional proposal to modify the 3-day inpatient qualifying stay requirement for SNF coverage, a new state law expanding observation status patient protections, or a Bagnall settlement implementation update from CMS. When those changes land, and the observation status issue has been in congressional consideration for a decade, you will know here before the hospital's utilization review team updates its internal criteria. Subscribe. Hit the bell. The families who ask the admission question on day 1 pay $1,632. The families who sign the moon without reading it pay $12,190. The question costs 30 seconds. The signature costs $12,000. Your sources are free. 42 CFR, Section 489.20Y, the Moon regulatory requirement is at ecfr.gov, the Medicare Benefit Policy Manual. Chapter 1, Section 10, the 2 Midnight Rule, is at cms.gov. Oregon SHIP is at oregonshines.org, or 8-0072-24134. The Bagnall Settlement Implementation Guidance is at cms.gov under Medicare Appeals. All 4 sources together describe exactly what observation status is, exactly what the Moon says, exactly what the appeal rights are, and exactly what Roger should have asked on the morning of September 15th. Be the family that asks the admission question before anyone signs anything. Don't be Roger, who signed the Moon at 11 p.m. on day 2 and paid $12,000 for care that Medicare should have covered. I'll see you in the next bulletin.